this broadcast we're going to talk about the bones, joints and muscles of the foot and ankle. The first thing to do is to recognize the categories of bones. So we've got tarsals, metatarsals and phalanges, as opposed to the hand where we have carpals, metacarpals and phalanges. And the tarsals are kind of blocky bones towards the ankle end of the foot, and then the metatarsals and the phalanges are more elongated long bones. We can also divide the foot into rear foot, midfoot and forefoot, which I've shown in this illustration here. This is a right foot skeleton seen from the lateral side, and going from left to right we can see the heel bone or the calcaneus. We can see the talus sat on top of that. The joint between these is the subtalar joint. Moving forwards we've got the navicular and the cuboid, and we can see some of the cuneiforms, and then we can see some of the metatarsals. The one that's lowest to the ground is the fifth metatarsal, and we can see a big tubercle on this. This is where one of the muscles attaches. Although all the joints in the foot probably work together, it's easier, I think, to separate the ankle from the subtalar joint. So that's what I'm going to do in this presentation, and I've just illustrated here the two different joints. This is the medial side of the foot. Again, you can see the calcaneus with the talus sat on top. Slightly different because the talus doesn't sit properly on top of the calcaneus. The calcaneus needs a wedge called the sustentaculum tali, which supports the talus. And then going from right to left, we can see the calcaneus at the base, the talus sat on top of the calcaneus. Then we have the navicular, then we have the first cuneiform, and then we have the first metatarsal. And you can see here one of the arches in the foot. So this is the medial longitudinal arch. The ankle joint itself is made up of the tibia, the fibula and the talus. The ankle joint itself is a hinge joint, or it's a mortise joint. So this is a carpentry term for a type of wooden joint, and this is a mortise that I've shown you on the right here. And what we can do at the ankle is wobble the ankle up and down into dorsiflexion and plantarflexion. Before we get down to the ankle, there are a few joints on the way down. So we have the tibia and the fibula, which are joined at the top and the bottom by the superior or proximal tibiofibular joint and the inferior or distal tibiofibular joint. There's not a lot of movement that occurs at these, but they do need to be quite strong. So there is a membrane between the bones called an interosseous membrane, and there is a slight capsule and some ligaments holding the fibula onto the tibia at the bottom. It's sometimes possible to rupture this syndesmosis between the two bones. I remember when I was a student I found it very difficult to get my head around where these joints were, so I've just tried to illustrate it here. We have from top to bottom a joint between the fibula and the tibia, that's the inferior tibiofibular joint. Then we have the ankle joint where the talus sits inside the mortise, and then underneath the bottom of the talus we have the subtalar joint between the talus and the calcaneus. This is a picture of a skeleton that I took. It's a right foot looking from top to bottom, in other words down into the ground, and the tibia and fibula have been removed. The bone that's closest to the camera is the talus, and you can see that it's wider anteriorly than posteriorly. That's important. You can also see how the talus doesn't sit perfectly on the calcaneus, and you can see at the front of the talus there is the navicular and a kind of ball and socket joint called the talo-calcaneo-navicular joint. And then going more anteriorly we have all these little blocky bones called the tarsals. We've got the cuboid and three cuneiform bones. You can see here, slightly exaggerated, the shape of the talus, which is wider anteriorly. So when the foot is dorsiflexed, it's the wide part of the talus that's in contact with the mortise, and the ankle is stable or close packed. When the foot's plantarflexed, it's the narrow part, so it's loose packed and it's less stable. So you're more likely to sprain your ankle in stilettos in a plantarflex position. And I've illustrated that concept here. And the fact that you're more likely to go over on your ankle if you're plantarflexed. Movements in the foot and ankle are quite complicated and they tend to occur together, but I'm going to split them into dorsiflexion and plantarflexion. So dorsiflexion is pulling the toes up towards you and plantarflexion is pushing the toes away from you. Whereas dorsi and plantarflexion occur at the ankle joint or the talocrural joint, inversion and eversion tend to occur at the subtalar joint. Inversion is moving the toe in to look at the sole of your foot, and eversion is moving your foot outwards. And these are important movements in walking, running, and also in walking on uneven ground. One of the central bones involved in all of this is the talus, and it's quite a complex bone. The talus is the only bone in the body that has no muscle attachments. I often think of the talus as a snail. So the top of the snail shell is the part of the talus that connects with the tibia and the fibula in the ankle joint. The head of the talus is the head of the snail. That's more anterior and forms a mini ball and socket joint in the midfoot. And then the underbelly of the snail would be the subtalar joint, where in and eversion occur. A fracture to the subtalar joint or the calcaneus is a serious injury and it causes a lot of pain and disability. Here's a picture of what's called a tongue-type fracture, which you can work out why it's called that. It's not an uncommon fracture. It's commonly found in window cleaners who fall off ladders. It's actually called a window cleaner's fracture. Also peeping toms. And also, I once saw a patient who'd fought in World War II, who'd been on a battleship that had been torpedoed, and the shock from the torpedo was transmitted through the deck plates, and most of the sailors on board had fractured calcaneae from the shock. Just thought that was interesting. On this diagram, from left to right, you can see the ankle joint, you can see the talus, and you can see the calcaneus under the talus. The green triangle is the sustentaculum tali, which is like a little buttress that juts out and holds things up. And you can see it in green here also. Because the ankle is a hinge joint, it has collateral ligaments. It's got medial and lateral collateral ligaments. This illustration shows you the lateral collaterals, and there are three separate ones. They come from the malleolus, and we've got an anterior and a posterior talofibula, and then a calcaneofibular ligament. These are not that strong. The weakest of them is the most anterior one, the anterior talofibular ligament, and they could be injured by something like an inversion injury where the ligaments are stretched. If you're struggling to find them, if you make this pattern with your fingers and slide them down the outside of your leg, it roughly corresponds to where the ligaments are, so that's a quick way to remember them. And here's a slightly more detailed picture of what the ligaments are, where they are, and what they're called. On the medial side of the ankle, things are different. We've got one thick ligament which has got four different components. It's called a deltoid ligament. Delta is the fourth letter of the Greek alphabet and it means triangular shaped. It's a very strong ligament. In fact, it's so strong that if you evert the ankle, it's probably more likely that you're going to pull the tip of the malleolus off rather than damage the ligament. That's called an avulsion fracture. If you follow the yellow arrow, you can see an example of an avulsion fracture here, where the tip of the malleolus has actually been pulled off by the ligament. The Greek alphabet's used quite a lot in medicine, so I thought it would be worth adding it here. You'll come across alpha, beta, gamma in terms of radiation. You'll come across alpha and beta in terms of nerve fiber types, and delta. There is the deltoid ligament in the ankle, and there's also a muscle called deltoid in the shoulder, which is triangular. Here are the four parts of the deltoid ligament or the medial ligament. If you're having a bad day in the exam, it's probably okay to just describe it as one triangular ligament. But if you're really pushing for higher marks, then there are four distinct parts to the deltoid ligament, two deep parts and two superficial parts, and here they are. One of the things that we have in the sole of the foot is the plantar fascia. The plantar surface of the foot is the undersurface of the foot. So you can see here the plantar aponeurosis or the plantar fascia. It's a very tough fibrous band of tissue that kind of acts like the lady here pulling on the string on the bow. It gives the arches of the foot the proper shape. Inflammation of the plantar fascia is quite common. It's called plantar fasciitis. So on the diagram on the left, I've shown you the common site of pain on the undersurface of the foot, on the medial tubercle of the calcaneus. And also, it's not unusual to get a little bony growth, a bony spur called a calcaneal spur, which can be very painful. Another thing that we have quite often in the body where there are numerous tendons are things called retinaculi, and there are some in the ankle and there are some in the wrist as well. Retinaculum in Latin means net, so it's actually a net that is cast over the tendons to keep them in place and stop them from bowstringing. You can see the picture here of a person who's ruptured the retinaculum of the peronei, and you can see how the tendon's no longer being kept in check as it should. In terms of movements of the ankle, it's a little bit tricky. If you just remember that this is 0 or plantigrade, and anything going up is dorsiflexion and anything going down is plantarflexion, then things are a whole lot easier. So this is just to show you what the typical movements in an ankle would be like. If you measured it with a goniometer, we've got about 20 degrees or 25 degrees of dorsiflexion and probably about 55 degrees of plantarflexion. In terms of muscles, you can divide them into posterior groups, lateral groups, and anterior groups, really. The lateral muscles are the peronei. You've got a longus and a brevis, and some people have a tertius. Not too worried about tertius, since some people don't actually have one. But peroneus longus is an everter and a plantarflexor. Peroneus brevis is the same, and obviously longus is longer than the brevis. Peroneus longus comes from the shaft of the fibula, goes down the lateral side of the leg, goes underneath a groove in the cuboid, and then slingshots under the surface of the foot. Peroneus brevis is not quite as long. It comes from lower down, and it actually attaches to the base of the fifth metatarsal, and on a patient you can actually see the muscle tendon going into that bony prominence. And the way I remember it is that the peronei are like the zip on a peronei boots. Thank you. In terms of the posterior muscles, we've got two main ones. We've got gastrocnemius and soleus. Gastrocnemius is a two-joint muscle. It comes from above the knee, so it will flex the knee and plantarflex the foot. Soleus comes from below the knee, so it can't do anything to the knee, and they both join together and form the Achilles tendon, which then inserts into the calcaneus. Gastroc has got two heads, a medial and a lateral, and you can see on this bodybuilder the heads are very well developed. You can also see where the muscle belly ends and it turns into a tendon. That's called a musculotendinous junction. You can see the Achilles tendons very well, and you can see soleus underneath the heads of gastroc. Don't forget that because gastroc is a two-joint muscle, it's subject to active and passive insufficiency. So if you get asked to analyze full dorsiflexion or assess full dorsiflexion, you need to flex the knees slightly, otherwise you won't get the full range of movement in gastroc. Tibialis anterior is the powerful dorsiflexor of the foot. It also inverts the foot, but one of its major roles is in gait. When your heel hits the ground, your foot has to be decelerated in a controlled manner to gently hit the ground, a little bit like this shuttle or an airplane landing at an airport. The back wheels come down first, and then gradually the front wheels come down. That's what tibialis anterior does. If you don't have a tibialis anterior, you've got what's called a foot drop or a foot slap, and somebody who's got that has a real problem with getting a controlled deceleration of the foot. There's also another small muscle at the back called plantaris. Pretty cool, but not too bothered about that. Not much goes wrong with it, really. There are some other deeper muscles as well, which you need to know the origins and insertions and actions of. There's a muscle that extends the big toe, that's extensor hallucis longus. There's a muscle that splits into four tendons that extend the other toes, that's extensor digitorum longus. There's a muscle that flexes your big toe, flexor hallucis longus, and there's a muscle that flexes the other toes, flexor digitorum. And in the same way that there is a tibialis anterior, there's also a tibialis posterior, which is a deep muscle at the back of the leg that goes down around the medial malleolus under the sole of the foot and attaches to numerous muscles under the sole of the foot. And our final muscle, I've included this just out of interest really, mainly because people don't know what it is. This is a muscle called extensor digitorum brevis. If you look at the dorsum of the foot, it looks like a greenish blue bruise, and people think it's a bruise and it's not, it's a muscle. And if you ask the patient to extend the toes upwards, it actually goes hard and it feeds into the tendons of extensor digitorum longus, which you can see here go into the person's toes. It's also quite useful because it's like a surface marking for where the cuboid sits really. We've also got three arches in the foot. We've got a medial longitudinal arch, a lateral longitudinal arch and a transverse arch, and the arches are responsible for giving the foot its strength and dynamic flexibility.